Neal Shah is a shareholder in the healthcare alignment and organizations practice at Polsinelli PC, a full-service law firm with one of the largest health law practices in the nation. With former experience with the Centers for Medicare and Medicaid Services and a safety net health system, Neal applies his legal and practical experience to help healthcare providers identify solutions to complex regulatory and transactional problems. He has experience advising accountable care organizations and participants in other value-based care programs and an ongoing interest in implementing innovative physician alignment opportunities. Neal.
Great. Well, so Dr. Jasser, thank you for agreeing to participate in this panel. And our co-speaker is Dr. Karen Smith. So Dr. Smith is a family physician with a private solo practice in the rural community of Rayford, North Carolina. She served on the North Carolina Academy of Family Physicians, North Carolina Medical Society, the Division of Medical Assistants Advisory Board, and the North Carolina Institute of Medicine. And she currently serves as the delegate to the American Academy of Family Physicians. She served on advisory groups for the Office of the National Coordinator and CMS Quality Payment Program as a physician champion. Dr. Jasser, I'm sure everyone knows Dr. Jasser, but just as a quick intro here, partly for CME purposes, Dr. Zuhdi Jasser is an internist in private practice in Phoenix, Arizona. He serves as chair of the AMA Private Practice Physician Section Governing Council. A Navy veteran, Dr. Jasser has served as staff internist to members of Congress and Supreme Court justices. He's a delegate to the AMA House of Delegates for the Arizona Medical Association, chair of Banner University Medical Center, Phoenix Ethics Committee, founder and chair of the Private Practice Physicians Congress, president of the American Islamic Forum for Democracy, and co-founder of the Muslim Reform Movement. He has previously served on the Maricopa County Board of Health, Board of Directors for the Area Agency on Aging, and as president of the Arizona Medical Association. So the topic of our discussion today is the opportunities for innovative contracting, given where we find ourselves at this stage of the pandemic and the ongoing attempts to both get back to normal and to preserve the ability of independent practices to survive and thrive in this context. It's a complicated moment for independent practice physicians here at the tail end of 2021. I'm going to hit some of just the very high level themes and trends in the market that we're seeing at the legal level. But I'd really like to open this up to the membership because I'd love to hear what you're seeing, and we'd love to field your questions and kind of help think about ways to promote the private practice model going forward. So first and foremost, COVID-19 has continued to transform the practice of medicine, and the healthcare market continues to have a serious effect on all practice management decisions. Over the last 2 years, almost every practice in the country has seen wild changes in patient volumes, staffing issues, including retention and just recruitment considerations, issues with continuity of care and retention of patients, and obviously impacts on practice finances. Some practices and some specialties and regions have bounced back. Many others have not. Some practices are actually doing well, given some of the practice changes that have occurred. Many of the practices who've gotten through this period have used temporary financial supports, flexibilities in policies and law, and rapid changes in practice focuses. For example, things like investment in things like telemedicine equipment or more sophisticated PPE. But if anything, the outlook in the near term is even murkier as we collectively navigate our way back to normal, despite a lot of uncertainty. Will existing payer policies around telemedicine and other things continue? Is it fair to judge practices' performance on cost and quality in value-based contracts over the last 2 years, using that time period as a baseline? What's the right way to manage changes in patient acuity and disease burden due to the interruptions in care over the last few years? Lots of uncertainty going forward as we emerge from COVID-19. The second key theme we're seeing is that government and payer policies are creating some significant headwinds for independent practices right now. Medicare is, of course, moving forward with cuts, significant cuts, nearly 10% for some specialties. Administrative burden continues to be an issue on the private payer side, whether that means the proliferation of prior authorization, ongoing delays with prior authorization, increasing rates of claim denials, and ongoing delays in getting data and other necessary information, as well as policies that in some cases reach into the relationship between a physician and patients. The variety of new policies may limit practices' ability to develop negotiating leverage in their interactions with payers. And then the third big theme we're seeing is that the healthcare delivery market is in a particularly fragmented and complex state right now. Consolidation is continuing rapidly. In fact, a recent AMA report found that fewer than half of physicians were engaged in independent practice as of 2020. It's likely that's changed further in the last year or so. It's harder for practices to develop leverage in existing fee-for-service negotiations for a host of reasons. We're seeing new kinds of disruptive care models that promise lower cost care, but at the expense of disrupting the traditional doctor-patient relationship. And it's unclear what the longer term impacts of those kinds of models will be. Very significant appetite has developed, I think, in watching how things have gone the last 2 years. I think many practices are very interested in moving away from fee-for-service to something else, but what that is still a little unclear. That could be everything from formal value-based arrangements, ACOs, or things like full risk capitation, concierge models, opting out of the third-party reimbursement model entirely. But it's complicated to stand these kinds of things up. Many practices don't want to jump in with both feet, in jumping into a full risk model immediately. So that means relying on third-party partners, and that raises its own whole host of issues in evaluating partners, understanding kind of what you're giving up versus what you're getting in return, and whether what you're paying ultimately is worth it. So a lot of interesting, important stuff going on in the physician practice management world currently. With that in mind, I'd like to turn to our speakers. We're very, very involved with promoting the independent practice model in very different settings. Dr. Jasser and Dr. Smith, let's kick off with the dialogue just about what you've seen in the last year. In particular, what kinds of examples have you seen of practices in this complex environment finding ways to survive and even thrive, given everything that's happened in the last 2 years?
First of all, thank you for allowing me to share comments on today. There is an update on my CV, and I am a board member for the American Academy of Family Physicians, and that election was one of a virtual one also in September. So thank you so much. In regard to my professional practice of 29 years in a rural environment, it definitely has been interesting in the fee-for-service market. And now we find ourselves in a blended payment model, and very much thankful for the value-based payment arrangement that we have with our accountable care organization. For this past year, as most of us, we were concerned when our patients were told to shelter in place, don't go into the doctor's office. And so how are we going to make telehealth work for us? We actually had telehealth 1 year or 2 years prior because we were doing medication-assisted treatment on a pilot platform, the recovery platform. So we already had telehealth. And we quickly asked if we could have all of our patients be seen on telehealth. Well, that was allowing the patient-physician relationship, that continuity of care to continue. But we did run into burden in terms of payment because we did have a dramatic drop in the funds and the monies that were coming in. But because of our value-based payment arrangement, we actually were able to receive those monies earlier in the year than anticipated. And that's what took us through, getting us right to the point for SBA loan. And we initially were denied because they could not determine the existence of our practice of 29 years' time. But finally, it did come through with some assistance from our congressional folks. But that set us up to be able to not only provide care for our patients during the pandemic, but also to be very actively engaged with vaccinations. We work with the Old North State Medical Society, one of the oldest Black medical societies in North Carolina, to provide vaccination to people of all community as a special project. And as of today, we are vaccinating children as well because of that project. So we certainly saw the changes to occur as a result of the pandemic, but we were also able to capitalize on our relationships with our ACO and really make the value-based payment model move forward. Last comment, North Carolina is going through Medicaid managed care, and we're making it work in that arena as well. So for us, we hope to share with our colleagues and to remain optimistic, as we just know that there was a major piece of legislation passed on the federal side, which in my opinion is an opportunity for medical practices to really innovate and create those practices that you're looking forward to. We'll move to our next speaker. Thank you so much.
Thanks, Karen. And I think to add my own experience, and I'm in private practice, internal medicine, primary care, and in a large in Phoenix. And, as for most independent practitioners, our, volume has never, or not never, but has rarely been a problem. But the problem is that you get paid the same and you're told to make up overhead issues with volume. And at some point that then compromises quality. And I think as Neal laid out, there's a lot changing around us, and there's headwinds to that change, and includes consolidation of insurance companies with hospitals and others. And I think one of the main messages I wanted to get out, and we can talk about it in conversation with all of you, is one of the paradigms I've shifted is, yes, I have my personal part of why I stayed. And I think, as I look at the audience here, I'm sure most of you have stayed in private practice, regardless of the storms around us, regardless of the rumors of our demise. We will probably stay through and through, because the expense, if you will, of handing over control of your business and your own model to somebody else is far too much than what we might lose on the bottom line when it comes to private practice. But having said that, I do think one of the shifts I've seen is that, in the past, in the hospital model, you used to have the doctor's lounge to meet the directors in the hospital. You'd interact and actually learn a lot about the business of medicine in that lounge. Now, not only are we not in the hospital, but in the outpatient setting, the interactions really have to be demanded. So I think one of the things I found that works is whatever ACO, I belong to, like most primary care docs, to one primary ACO. And in that ACO, as my meetings have increased, even though it takes more what seems to be unfunded time, and I think you have to sort of look at what a widget is different than we used to 5-10 years ago. So a widget used to be fee for service. You get paid for that visit, and $80, level 3, level 4, whatever it is, and you think that that's the bottom line. Now, because there's different surges and incentive payments that happen, and one of my biggest complaints is the lack of transparency there, and also the length of the feedback loop. It takes 12 to 18 months before, we just got a check a few weeks ago that was for 2020, and I don't even remember if I have the same staff. Most of us have had huge turnover, so to give them feedback on what we got paid for and what we didn't, it sort of seems way after the fact. But I will tell you, as I increased my regular contacts with the medical directors, with the folks that send us diagnostic sheets, with the liaisons that they have with the practice, and made that a priority in the culture of our practice, because as the plans then improve their RAF scores, improve their diagnostic codes, we get paid more. So that sort of becomes part of the widgets, if you will, in that I started to shift a certain part of the time that me and my managers provide to the insurance companies, to where I start to have a regular process in which we demand that they come in, and they've now provided software packages that can, through one's called InNote and others that attach to our EMR, that provide better integration for diagnostic capturing. So there's things that they can do that I think a lot of docs, as I talk to folks in the community, other community docs, don't realize that you can do with better connections. They provide many things to let you know about formularies and other things that you would not realize had we not had regular meetings with them. So I think that's sort of been a bit of a paradigm shift, as painful as it is. I do think that it helps. Let me leave it there. There's other things on contracting and things as many new plans come out, but I think I'll turn it back to Neal.
Thanks, Dr. Jasser. It raised an interesting question there, and I think it's one that many practices are struggling with. I think a lot of practices know they want to change the type of relationship they have with payers, whether that's moving to a value-based model or just exercising, greater resources associated with maximizing risk adjustment factor or otherwise, helping the plan move to a more integrated population health model. I think a lot of practices would love to hear more about where you start. Where do you start that kind of conversation with the payer? What do you recommend in terms of practice investments, in terms of understanding your practice, in beginning that interaction with the payer and kind of convincing them that you're a partner that's worth investing in?
Well, if I may, and it's interesting, and it's being in medicine for this long and being in my own practice, I've had opportunity to watch the evolution of what's occurring in our payment models. We initially started off with a CIN, a clinically integrated network. And one of the major hurdles for that group was the fact that we could not get a common platform in terms of our data, our management, our patients. It was very difficult. And finally, we did land one, but it was very expensive. Well, at that point, we kind of moved over into the MIPS area, and we recognized that the group was large enough that we could actually qualify for the other types of contracting. And yes, they did receive shared savings in the first year, but in the second year, because of the cost of the platform, I don't believe that they really had positive balance in that. I then found that when we had our practice transformation networks, which subsequently many of us started to join the ACOs, because remember the PTNs, the whole purpose was to set our practices up so that we could fare well in a quality payment model. And those who did participate really could make some differences in their own practice infrastructure and allow them to actually perform well, or at least be able to perform in the ACO type models. And what I find now is those entities that present that have a very good data collecting model, that we do have connectivity to the quality payment program platforms. Again, some of us might remember QR/UR, where we could access that data, but now we can go through our ACOs and see that information. But I think the key for North Carolina was the fact that we had a relationship with one of our largest payers as part of the ACO model, and to have a private payer connected with the ACO and also have the Medicare Shared Savings Program allowed us to receive benefits on both sides of it. But if I had to say anything to a practice who's listening today, make sure your data infrastructure is intact, because we can't do population health medicine very well without good data. Registries are fine, but really make sure that whatever entity you connect up with, you have a really good platform, is working and is truly exchanging information at the time of service and point of care.
Dr. Jasser, anything you'd like to say?
Yeah, those are great comments, Karen. And I think I would add basically three major points. One is get involved in, as painful as it is. Remember, in hospitals, we were all involved in committees, and I still admit, but most of that, my committee work in the hospital, other than the ethics committee, has dropped off. I do think it's similar. We're not used to that same structure in the outpatient setting. So I found that as I got more into governance committees, they have a primary care governance committee that I'm involved with the ACO. We've got credentialing committee. There are some financial committees. So they have to have a certain amount of transparency. They're not going to tell everybody in the plan a lot of that just because there's no way to do that. But as you get involved in these committees, you start to see how the proverbial sausage is made, and you can have some input into understanding some of their limitations fairly, to be fair. but also to then let them know so that you shorten the distance between people making decisions and what's happening with your office on the front line. And that's led to other relationships where, when they come hand off an incentive check to us, it's more of a personal relationship rather than just sort of something that's mailed to whoever. And you also start to see other practices that are, mine, for example, a lot of times we're at 60, 70% data gathering, and I see some at 95%, and, you're trying to figure out how they get there. So it's good to have contact with other practices and see some of the data so that you can understand that. Second is, remember that these insurance plans have marketing arms. I found one of the Easter eggs, if you will, is remember that a lot of them now, especially with hospitals joining with the insurance companies, and now the hospital companies being in insurance, many of them are starting new Advantage plans or whatever it might be. If you've been with them for a few years, you're going to be one of the most influential, as your patients decide what insurance plan they're going to be on. The plans can either tell you how they're going to market, or you can be part of that plan because it's easier for them to get docs to, have the brochures in your waiting room and be involved with why patients switch so that they stay with their doctor rather than coming to a plan per se. And I think that's another thing that we forget sometimes is most patients come to their doctors and ask us what plans we're on. They don't go to the plan. They might see that from their insurance agent, but at the end of the day, we need to be better at being part of the marketing aspect. Third is sort of a quick bullet is there's a lot of folks out there that'll come and promise you, even, large physicians groups that'll say, we have our own ACO. We'll get this 20,000 more or 40,000 more a year for you. Be careful, because the grass always seems greener. And sometimes I've talked to folks that have sold or, not sold necessarily, but they have these independent methods in which they let you stay independent, but then they take over your tax ID. Most docs lose the independence that many of us are in this right now for. And once you lose that independence, that monies they promised us often does not end up materializing. It ends up being a wash.
So you both are very involved in non-fee-for-service models and moving to non-fee-for-service models. In your experience, what are some of the major factors for success in those models, especially in an independent practice setting, a setting where you're not necessarily dealing with a large multi-specialty network or a hospital partner in that kind of tightly integrated network? You want to stay independent. How does a value-based model or a non-fee-for-service model fit into that strategy?
I think the first thing that I would say is to make sure that you're engaged. If you're part of an ACO, there's a tendency for some of the practices, and I'm a local medical director for ours, but there's a tendency for some of our practices to delegate the work of just doing gap closures or care lists, and they'll delegate it completely either to the management staff or a clinical staff member who really doesn't understand what's going on. Well, when you're trying to do your risk coding and set that benchmark, it's very important. And when that data goes in the system in terms of gap closure, it's very important. So if you're going to delegate this work, then make sure you follow through. So we need to remain engaged. When it comes to having our meetings, as we already know, all of us are pretty busy, right? So participate in the meetings, and we definitely want you to be part of those board of director discussions so that you are making a decision. You are actually deciding in terms of what your payments should be and what does it entail for you to get those payments. Again, we are not in a administrative system where we are at downstream. We're working upstream. And this is what we mean by physician-led ACOs. We are upstream. We are creating the plan. We are determining which insurance companies are going to be most beneficial for us to participate with. But if you want to continue to be on the receiving end, you're going to get just what you're going to get, depending on how much time you put into it. So that would be my first thing. Be accountable, be responsible, but stay connected and engaged.
Okay, Neal, we have three questions. So let's start with Chris, Dr. Garofalo. You're recognized. You can raise your hand in Zoom.
Thank you. One of the things that we haven't yet talked about, and I think that's just because the two participants don't necessarily participate in this kind of practice, is one where you eschew the third-party models altogether. One of the things that I've seen in my 20 years is, every time we move towards fulfilling one of the things that the insurance companies want us to fulfill, all of a sudden the goalposts change. And I don't know that I ever see that changing. And I'm becoming more and more convinced that we as physicians, quite like Dr. Smith was just talking about, need to take more control of these systems that we're in. That includes ownership of hospitals, it includes, being more part of insurance companies, but even going down to the level of just directly contracting with our patients, and whether that's a concierge or a DPC type of model. And I'm just wondering if someone will be able to talk about that, because it just seems like we just keep getting further and further down the rabbit hole. And when you meet the MIPS criteria, they come up with new ones. When you meet what the insurance companies want you to meet for HEDIS, all of a sudden your HEDIS numbers now go from 85% to 92%. And you're just never going to get there. And as long as you're dependent on a third person for your livelihood, it just seems like we're going to be in this unending spiral. Thank you.
Neal, did you want to talk about that from a national perspective? I ask you because I think part of the reason many of us have stayed in is that I don't know what percent of the total GDP, healthcare GDP, is in insurance industry versus cash industry. I think that's part of it. It's just sort of the elephant in the room is insurance. But again, I don't, and just to predicate before I get your comments, Neal, I think, I've never, in many ways, the fact that if you're insurance based should not mean that you're against folks being direct DPC or concierge. It's just that that is a big transition for folks that involves abandoning patients and doing things that, not that you all do that, but for us to switch, the switch is a big shift that can be difficult, if not impossible, for many of us to do, depending on the populations where we practice. So. Neal.
Yeah, that's a great point, Dr. Jasser. We are seeing concierge models grow in popularity. I think that they have a lot of immediate appeal for especially independent practices. They are challenging just from a structural and legal perspective. As you said, the market share is a significant part. Many of your patients are enrolled through third-party payers. The other thing we're seeing is that there are often third-party payer policies that make it hard to work in a hybrid model. So you're saying I'm accepting some third-party reimbursement, but I would like the bulk of my reimbursement to be concierge and directly reimbursed by patients, directly paid by patients. There are often contractual provisions and payer policies that can limit your ability to actually do that. The other side of things is that very frequently a large share of your payer mix is going to be Medicare and Medicaid, and particularly Medicare makes it tough to opt out. It's not impossible, but it is tough to serve Medicare beneficiaries while not accepting assignment. And so there are just these operational challenges. It's possible to get there. But the thing we've seen with concierge models is very frequently practices kind of make an all or nothing choice fairly early in saying, we're going to be all concierge, or we're going to be directly contracted, typically with an employer more than with patients directly, but we're going to enter into some sort of direct contracting model. And that's it, and not necessarily operate as a traditional physician practice, tapping into relationships with multiple payers. Now that works for some practices, but it's an important strategic choice, and one that often carries significant implications as a result. And Dr. Smith, you're operating in a slightly different region than Dr. Jasser or where I am in Chicago. Have you seen many concierge models in your more rural area?
We actually do have some practices that are concierge, and you're exactly right. These physicians have decided that they no longer wanted to work in the straight fee-for-service market. But we also have some practices that have gone to DPC, and some may know it as a direct primary care model. That too is restricted because it's a very low panel, often under 1,000 patients, and working exclusively for those individuals, for those patients. But it also decreases the overhead dramatically because your staffing almost goes away. It's yourself and usually one other staff person. Your requirements in terms of the electronic health records could be as simple as you make it. And they are doing quite well with that model. But those of us who are in the rural area recognize that we're dependent upon our public payers in terms of Medicaid and Medicare. But so the opportunity to become a little bit more innovative with that blended payment model is what we are currently working with now. And we find that the innovations that can occur, and again, I'm so excited because I absolutely see so much room for innovation. I think it's an opportunity for us to tell our payers what it is that we need in order to provide good, accessible, efficient, and quality care for our patients. And so this is an opportunity for us to lay it out on the table. Let me also say this because there was some comment made regarding benchmarking and how that changes. Well, believe it or not, we pay into that. The data that we put in, we are putting that data in. And if we're not letting the payers know the acuity level of the patients that we're caring for, what are we going to get in that risk model? So we have to be very careful for that. And the other component, SODH. We know social determinants of health factors, they matter 70% of the time in terms of producing that quality or outcome that we're looking for, yet our payment is contingent upon achieving those outcomes. And when we look at where those measures are in their systems, and we know with FHIR, which is our interoperability system for those measures, they're not even in the system in terms of you're being able to access someone having a SODH issue and actually documenting it and getting it on a claim form so that our payer knows that this individual cannot access care because they're in a desert, food desert. And when these measures are not showing up, but yet it impacts 70% of what we're getting paid. So there's a lot of room here. And there's a lot of conversation that still needs to occur with our CMS folks and with our private payers.
All right, Neal, we've got a question from Dr. Gold.
Thank you. Can you hear me?
Yes.
Yes.
Yeah, I'm a solo neurologist in Eastern Massachusetts and being overwhelmed by the systems around, even though I'm on an IPO actually. But I have a couple of global comments that should have some answers, at least speculatively. One is I've consistently had problems with the idea of value-based medicine because value is proportionate to quality and cost. And well, what is quality in my field? You know, hypertension and diabetes are fine. You can measure numbers, and those numbers actually reflect something of quality care. But when you get into chronic care situations and or degenerative situations that are going downhill, how do you measure quality? I don't mind being measured by a reasonable metric, but there doesn't exist much in my field. Number two is, so the value-based stuff is grating to me. Second thing is when you say get involved in local or regional leadership, that's fine. I've tried to. There's a cliquish sort of thing in the medical industrial complex, even locally. So that is not as easy as you think, but certainly stepping up is important. And as part of OMSS, the committee of policy I'm heading, I want to. We're going to have a webinar possibly on the state of unionization, which is another way of going about this. Is it feasible? The AMA actually has a white paper on something like this within the last 3 years. So apparently we won't be run out of town to at least discuss that. And I would hope that you would either comment on that or be aware that we may come up with a webinar like that. Thank you so much.
Great. Thank you, Dr. Gold. So a couple of different issues in that question. The question around chronic care measurements and how do you tailor value-based care to all specialties? Does value-based care even make sense for all specialties? I think that's an important one. I think it's one that, both the federal government, payers, physicians, and specialty societies have all been wrestling with for better part of a decade at least. I'm curious to hear your take, Dr. Smith, Dr. Jasser, on, how that process should work, especially in some of these specialties where you may not have the numerical metrics that necessarily are obvious markers of quote unquote quality. I will say on the Medicare side, there has been this shift toward the MIPS values pathways that are more aligned with specialty societies, taking into account more specialty society input. And I know that's something the AMA has been working on as well. But I'm curious, especially Dr. Smith, given your experience with QPP, what opportunities are there, and are there opportunities for feedback and input into some of these more complex value-based metrics?
And it's an excellent question, and it is one that came up very early on as we were getting the meaningful use and the quality payment program rolled out. What about our specialists? What should they be measuring, and how should they be reporting? And so what we're seeing is the MIPS value-based payment model, where now we are looking at those measures that make sense, right? Measures that mean something to you, and measures that you can measure in your specialty. And I think it's very important, as this is being rolled out, to continue to give feedback to your specialty societies, letting them know, yeah, hey, I can measure this, or no, I can't measure this, or it's not making sense for the majority of our population. That information is so valuable. We have to remember that MIPS is the QPP program is still fairly new. And unfortunately, we had the pandemic to literally slam down in the middle of it. And now we're still being held accountable for this year. But we need the feedback, and definitely reach out to your CMS colleagues. I also heard the comment of difficulty of connecting in with your local colleagues, your local specialty members. And it's interesting, in my community, we don't even have a neurologist. We have no specialties. Everything in our area is primary care. But what it says to me is that we have to work closely with our specialty members, with our neurology colleagues. And so we are seeing that occur also with the ACOs, allowing that conversation to occur. So no, you shouldn't be the one measuring the A1C, but as a primary care physician for diabetes measurements, I should be the one measuring that. But when we have our CINs, our clinically integrated network, the bottom line is the outcome in terms of the quality of care for that patient as part of the CIN will be enhanced, because we are working together with primary care and specialty medicine, and we are all seeing the performance. I'm going to say this also. Our payment models need to change, and primary care for so long was not getting the payment that allow us to provide that care. Now, the NASM consensus study came out in terms of, this is from the National Academy of Sciences, Engineer and Medicine, in terms of rebuilding healthcare. And we are seeing with that report opportunity for primary care to really take a stance in healthcare delivery. But we need our specialty colleagues. In our community, we need all of our physicians working together to ensure better care and better outcome for our patients.
Yeah, and I would just add one thing, and we have a few more questions, Neal. My biggest, and I think you all have hit on this repeatedly, is and Dr. Gold also did, is the lack of fairness of simply looking at A1Cs and some of the objective data. When I was mentioning in my earlier comments about my practice's 60-70% achievement on, let's say, annual wellness visits, while some practices get 90-95%. I'm not sure that's a measure of quality, that I finished an annual wellness paper drill with a patient versus actually having seen them. And sometimes patients don't want to do that. I think the fix is somehow including patient evaluations, patient wishes. That's really why concierge works for us, is because, you know, for many of us is that you sort of get the sense that the free market will determine which doctors patients want to see. And if they need to figure out how to factor in I even think with a greater factor, what the patient feels about the quality of care they're getting, the relationship they have with the doctor, and how comfortable they feel. And I can tell you now, they've started this QR code where they fill out a survey on the way out of my office. It's better than it was without that. But even with that, it just touches on the surface. And, you know, this isn't new. Hotel industries do this. A lot of service industries have methods of figuring out what patients like and what they don't, or what customers like. And I think in healthcare, we should be able to do that and get paid better if our patients are ecstatic at the way we take care of them. Next, Roxanne, Dr. Tyrock has a question about Village Medical and Pharmacy and practice.
Yes, thank you so much. I hope this is within the context of the type of content that we would cover today, but we have had a few folks move out of the hospital employed model into the village medical model. And I did attend one of their meetings just to learn about their model. And it is Walgreens based. And I did want to see if you had any comments or any insight into this relationship. It just appears that there would be some conflicts that may make this a complicated relationship. For example, a few years ago, the controlled substance regulation went from the Department of Public Safety in Texas to the Board of Pharmacy, and you can see how that could set up conflicts. Anyway, I'll let you elaborate.
Well, unfortunately, I can't really comment on any particular model or run by a particular entity. I will say there are lots of kind of these hybrid models that involve a management component as well as a contracting component, and in some cases an affiliation with a larger corporate partner. I would just say, in entering into any relationship with a partner along those lines, you should just understand any implications in terms of locking you into a particular vendor or particular third-party relationship. But I can't, unfortunately, comment on any particular entity.
Two more questions.
Great, okay.
One was from Dr. Reggae and the other was from Dr. Elaine Choi. Dr. Reggae, she wrote maybe she's available to give the question herself. Yes. Go ahead, Sheila.
It just seems like with, year to year, we go through the hospital-based payments and the OPPS. And I know I'm on the council and we've tried to figure out, kind of don't draw everything down to kind of the outpatient, the OPPS, but make it a little fairer. And then one point Medicare did site neutral, which kind of, I know, scared everybody. Do you see any relief in sight, or do you have any advice for this group on how we can, ensure that we have enough reimbursement to survive, especially with labor costs being so high? And the challenge that even the fast food industry is hiring people at, right now in my town, $18 to $20 an hour. Amazon's coming in and warehouse, and they're going to pay with benefits and stuff. So do you, any recommendations for our group?
And this issue was one, we were meeting with our own North Carolina Senate, one of our senators yesterday. And this issue is very, very of concern, because we know that we're losing medical staff to other industry. Lowe's is competing with our medical staff. And we all know the cost of bringing someone on board and training them and getting them part of the process, and then we lose them. And I really think, at least from the primary care side of the house, that it really goes back to making sure that we have the value in terms of what it is that we do as a physician, and that we are able to get the payment that goes along with that. And so again, I encourage each of you to please take a look at the NASM consensus study, because the payment is part of that. And it's very important, or else we're not going to be able to sustain our businesses. So the staff shortage is an issue, but I think the value of the physician is an issue. I'm also going to say one other thing, the scope of work. And that has become a problem when our hospitals are losing our nursings who want to go into more of advanced practice models, yet we don't have enough individuals to staff those beds or to run tests in radiology or whatever. So the staffing does have impact on us, even though we're in the independent practice office. But if I can't get the tests that our patients need, or they can't go to the OR because of the nursing shortage, because we're into this scope issue. So I think there's a lot more discussion that needs to occur. Neal, I'm going to turn it over to you for the business, other business components.
Yeah, that's all extremely important. The other thing I would say is just remember that the primary avenue for paying for all of your practice staff should really be the PE component of the relative value unit, and the AMA has a direct line into setting and making recommendations, at least as to the weighting of the RVU. And so that is an area where I would recommend, staying engaged, getting engaged, making sure you're collecting and sharing data, because that seems to be an area where the historic trends are just maybe not as applicable as they historically have been. Certainly role to communicate to AMA and with CMS, which ultimately sets at least the Medicare rates. So unfortunately, that's not a quick fix, short-term solution. We have seen at least some flexibility in resetting what it counts as fair market value as these kinds of rates have increased. So for example, this is less of an issue with office staff, but it is a significant issue at times with mid-levels and with more highly trained technicians and other staff. Folks sometimes, or practices sometimes get concerned about the ranges of compensation they're paying. We're seeing flexibility in that area. We're seeing more understanding that the rate needs to be driven by the market, and the market for labor has just changed. And so there may be some flexibility there. Unfortunately, some of this, though, is just the nature of staffing in every industry currently, right? Not just healthcare. However, healthcare has faced its own burnout issues, and so there have been things like employee wellness programs, incentives for retention, things that are intended to at least keep your existing staff happy and keep them close by.
Our last one, Elaine Choi has been waiting a while, so I didn't mean to interrupt you. I thought you were done. I'm sorry.
No, go ahead.
But he'll be our last question, and then you can close it out.
Thank you so much. A lot of my question has been answered. Thank you, Dr. Smith. Thank you, Dr. Shah and Dr. Jasser. The insurance companies are upping up the ante in terms of the administrative burden that is now burning out our staffs. I have a few people walk out of my office because of the amount of phone calls that has increased during the pandemic, the amount of the prior authorizations, the decreased reimbursement, the increased burden, administrative burden is making a lot of our colleagues retire early, and our patients are feeling it right now with the lack of staffing, the lack of access to care. So what's happening is access to care is being compromised, especially when Dr. Smith was talking about the social determinants of health. A lot of our patients that can afford direct primary care or concierge medicine are okay. But what we have noticed lately that our patients that need it the most are not able to access even primary care because of all we talked about, and especially specialty care. And I don't know if there is a light at the end of this tunnel, as the crisis in access right now in our state in Massachusetts are to the point where they are hiring physicians, nurses from other places for double or three times from companies that do not, I don't know what they call them, the hire, doctor for hire.
The locum tenens or travel nursing model.
Locum tenens, yeah.
If I can address the administrative burden reduction, that is like the top of the list. I mean, everybody on here who has not had a prior auth, at least, 5 in a day, right? That is a major issue. And I think some of our colleagues, particularly Texas, with the gold card, with the agreement that they came up with one of their private insurers. And those are the kind of models that it would be wonderful to study a little bit more. And how can we implement that in other areas? We know that the MIPS pathway, the QPP program, again, what can be done for the administrative burden reduction? That's leading to burnout. Not only our staff burnout, it leads to burnout of the physician. It makes that happiness in medicine goes away. And those are the things exactly that we need to deal with in order to bring back that efficiency and bring back that joy of medicine. So again, I'm super excited about the opportunity for innovation. I'd like to chat with our colleagues from Texas and ask them, how did you guys do it and how is it working? And is it something that we can bring to our other states? We must address administrative burden. We must address our physician burnout and our staff burnout. And we need to pay close attention to our payment models so that we do have enough money to run our practices and, quite frankly, get paid as a value of a physician.
One other thing along those lines is some of the challenge with burnout and with administrative burden is attempting to practice in both a fee-for-service model and other kinds of models at once. Because depending on what's going on, fee-for-service tends to create pressures to push back on medical necessity of individual procedures. That is a challenge when you're attempting to both handle the kind of administrative exchange associated with fee-for-service, while also attempting to manage things from an overall population health level and actually spend the additional time and attention and care associated with handling care coordination, following up with your patients, ensuring that social determinants are met, which can just suddenly start to compound the actual overhead, both in terms of staff time and just emotional and just time effort. So absolutely important topic, and administrative burden. We have seen that become maybe the top issue for the private practices that we've dealt with. Dr. Jasser, I don't know if you have anything else to say on that.
No, I think we can go to the closing comments if you want.
Okay, absolutely. Yes, well, thank you everyone for the time, and thank you to our panelists for your insight in this topic. I think this is a very important topic. If you have other questions, please do send them to the section staff. We'll do our best to respond. And this is very helpful for us to hear, very, very educational to hear what's happening out there. Always very rewarding to kind of work with private practice physicians to understand your issues and your concerns. And so please do take the opportunity to reach out.